Next talk is by Dr. Alok Singh. Alok Singh needs no introduction, and his talk is Management of the Heart Failure in 2025.
So, heart failure is the ultimate destination of any heart disease. Ultimately, any heart disease is there. If it is not treated, even if it is treated, ultimately it will develop heart failure. An estimated prevalence of heart failure in India is 1.3 to 4.6 million, and around 2 million hospitalization annually in India is because of heart failure, and it is one of the leading cause of hospital admission in elderly population. And patient with heart failure admission in India are quite younger in India. It is around 53 years if we compare from the US and Europe patients. So approximately 20-year older, younger in comparison to the Western counterparts. And if you see in hospital mortality during the acute decompensated state in heart failure in India is 10 to 30% in various studies, but in Western countries it's around 4 to 7%. And heart failure is not a single homogeneous entity, it is a heterogeneous entity, and it's a chronic condition interspersed with the acute episodes. And with each acute decompensation, the downhill fall is very fast. You can see downhill fall is very fast. So, reduction in recurrent hospitalization need to be taken care. So, you can note down for each hospitalization there is a sudden steep downfall in the overall survival. Now, before 2021, there was no universal definition of heart failure. Now there is a clear-cut definition which is being adopted by most of the international societies. Heart failure is a clinical syndrome with current or prior symptoms and or signs caused by structural and functional cardiac abnormalities which must be corroborated by at least one of the following. One is elevated biomarker in the form of natriuretic peptide level or objective evidence of cardiogenic pulmonary or systemic congestion. So this definition is complete, and there are four stages of heart failure. Stage A, the patient is at risk of heart failure, like patient of hypertension, diabetes, coronary artery disease, history of cancer, cytotoxic drugs, but they don't have any structural or functional disease of the heart. Pre-heart failure means there is a structural heart disease. There may be abnormal cardiac function is there. There may be elevated natriuretic peptide level, but there is no symptom. And stage C is a symptomatic heart failure patient, which we usually treat in our day in day out in clinics and hospitals. And advanced heart failure is stage D, where severe symptoms and signs of heart failure, in spite of all guideline directed therapy, patient is still symptomatic. In these subset of patients, we have only option of LVSS devices or heart transplantation. And another classification of heart failure is by ejection fraction. If ejection fraction is less than 40%, heart failure with reduced ejection fraction. If it is more than 50%, heart failure with preserved one. In between, it is a mildly reduced one. And another newer entity came that is known as heart failure with improved ejection fraction. So approximately 1/3 of patients ejection fraction improve over the period of time. So heart failure with baseline LV ejection fraction less than 40% and with a 10-point increase from baseline, and second measurement should be more than 40%. So we label as a heart failure with improved ejection fraction. And most of the time we see physicians are very much कि इसका ejection fraction इतना था, अगली रिपोर्ट में इतना कैसे हो गया. So it is a dynamic condition. If you can see heart failure with preserved ejection fraction, if you follow them, 60 to 90% will have same EF, but 10 to 20% will deteriorate. And in HFrEF, approximately 1/4, 30 to 40% patient, ejection fraction will improve. So earlier, when the ejection fraction was improved, then it was labeled as a heart failure with preserved one. But now it is labeled as heart failure with improved ejection fraction. So we can understand, earlier it was less, now it is normal. So because these two conditions are pathophysiologically different. And in heart failure with mild reduced ejection fraction, between 30 to 40% will remain in the same. Means in this subset, one third will improve, one third will deteriorate, one third will in the same. So that is very important slide. So heart failure is a dynamic condition. And if you see the treatment of heart failure have all started with diuretics and digoxin. But over the period from 1987, first the consensus trial came when the ACE inhibitor have come the first drug which have reduced the mortality and morbidity over and above the diuretics. Then in 1996, US carvedilol study came which for the first time have shown beta blocker over and above ACE inhibitor in the management of heart failure. Then in 99, Rails trial with the spironolactone have shown 30% reduction in the risk of death over and above ACE inhibitor and beta blocker. And after a long period, after 15 years of 1999 Rails trial, paradigm HF came which have shown if we use instead of ACE inhibitor ARNI, then we have significant reduction in mortality and morbidity. And in 2019 to 2022, SGLT2 inhibitor is another class of drug came which have shown difference in mortality and morbidity with the use of SGLT2 inhibitor. So from 2019 onward, we came with the 4 pillars of the heart failure therapies. So now coming to the comprehensive management of the heart failure. In heart failure stage A means hypertension, you treat blood pressure effectively. Diabetes, all diabetic patients you have to give SGLT2 inhibitor if you really want to prevent heart failure event. Then serious disorders, coronary artery disease effectively need to be treated either by medical management, either by revascularization. And cardiotoxic agent, effective management need to be given. Any patient with the genetic cardiomyopathy, cascade screening need to be done and effectively need to be treated. And stage B means patient with structural heart disease is there but there is no symptom. Accidentally you have diagnosed them. So here, this is very important. Here we have the role of only 2 drugs, ACE inhibitor and beta blocker. So in stage B, ejection fraction is less. For the prevention of symptomatic heart failure from the asymptomatic stage, we have the role of ACE inhibitor and beta blocker. In this subset, there is no role of ARNI. And for sudden death prevention, ICD is there. And stage C, 4 pillar, ARNI, beta blocker, MRAs and SGLT2 inhibitor and diuretics as one needed. So ARNI, beta blocker, MRA, SGLT2 and diuretic. If still patient is not improving, then we have a long list of other therapies like ivabradine, hydrogen dinitrate, vericiguate and all. And for prevention of sudden cardiac death, ICD is recommended if ejection fraction is less than 35%. If there is a left bundle branch block, QRS duration is more than 150, then cardiac resynchronization therapy is recommended. And if still your patient is not responding, it means it is a stage D heart failure where LVSS devices and cardiac transplantation is recommended. And optimize right and optimize tight as early as if you are treating the patient. If you see all landmark study, the curve have started very early after starting the drugs. So as early as you can give all 4 drugs, that will be the beneficial. In the strong HF trial, I have consistently demonstrated from the usual care group, if we start very early, the curve have started separating. So as early as all 4 drugs on to the counter we have to take. And if all 4 drugs we have given and patient is having persistent volume overload, then diuretic dose need to be increased. If still patient is you cannot have a chronic kidney disease or black population, then hydrogen isosorbide dinitrate. Still in a spot of maximal tolerated dose beta blocker more than 70 heart rate, ivabradine you have to consider. And for preventing recurrent heart failure hospitalization, vericiguate. But in Victoria trial, SGLT2 inhibitor was not used. That we have to remember. So that's why it is a class 2B. And lenoxin is also being used in patient on AF and all. So indication of vericiguate, LV ejection fraction less than 45% on maximum tolerated GDMTs and worsening heart failure symptoms. Initial dose should be 2.5 milligram per daily and you have to double the dose every 2 weeks. Target dose should be 10 mg daily. And if you see across the stage, SGLT2 inhibitor is a class 1. SGLT2 inhibitors and loop diuretics, these are the only 2 green. across the spectrum of ejection fraction. So, loop diuretics have not been shown to demonstrate survival, but most of the patient need it, and all other patient you have to choose. And SGLT2 inhibitor, if you use, it reduces the chances of hyperkalemia. So by using SGLT2 inhibitor, chances of adding RNA becomes more and more. So during hospitalization, GDMTs need to be maintained if there is no contraindication. So this is a class 1. And you have to titrate, and if your patient is not tolerating, then the mnemonics is I need help, means frequently requiring intravenous inotropes, NYHC 3, 4, persistently elevated net neutralizing peptide, end organ dysfunction, ejection fraction persistently low, if on ICD, persistent shock, more than one hospitalization in last 6 months, edema despite escalating diuretic agent, not able to tolerate ACE inhibitor and MRAs. So titration strategies may be varied, and if you see the most beneficial drug, if you see overall, if you will go by the rare data, then MRA is the most beneficial, but once you characterize it by the risk factor, then beta blocker is the most effective drug. For 5-year number needed to treat is 8. And another study, get with the guideline heart failure registry, approximately 23,000 patients, 82% patients were eligible for the quadruple therapy, and what they have shown, if you can give all 4 drugs, then you can reduce the absolute risk reduction by the 25%. It's a huge reduction by all 4 therapies. So number needed to treat will come around 4. And sequencing, earlier sequence was give one drug, then another, then another. So usually it takes more than 6 months. Now the most accepted it start with the beta blocker and SGLT2 inhibitor, because SGLT2 inhibitor have a diuretic action. Beta blocker is a maximum reduction in sudden cardiac death. That is very high chances in initial phases. And then within 2 weeks add ARNI, and in another 2 weeks add MRA, depending upon the hypotension or potassium level. If hypotension is there, then add MRA first. If there is a hyperkalemia first, then add ARNI first. So all 4 drugs in 4 weeks, and gradually up titrate over 3 to 4 months. So anticipate for hypotension, declining EGFR and hyperkalemia when you are up titrating the drug. So for individual not receiving any GDMT at the time of their HFrEF diagnosis, clinicians should aim to achieve optimal 4 drug GDMTs no longer than 3 months following an initial diagnosis of heart failure. So you have to go maximum all 4 drugs within 3 months to maximum tolerated dose. And reassessment of ventricular function should occur 3 to 6 months after the target dose of GDMTs are achieved to determine the need of device therapy like ICD and CRT. So always the question comes when to assess. So after full therapy 3 to 6 months. So, and when you are up titrating ARNI, you have to see whether we are not using any drug which are unnecessary like calcium channel blocker, which are not needed in this. And if you see SGLT2 inhibitor in solo cis WHF in acute decompensated heart failure patients, it have reduces the heart failure event by 129%. Number needed to treat is 10. So based on this solo cis WHF, although it was in diabetes with acute decompensated, now SGLT2 inhibitor have been recommended as a class 1 in acute heart failure also. And IV iron in iron deficiency is recommended variciguate to prevent the recurrent hospitalization, but it should be after all 4 drugs have been given. So if you see the pillar, it is a complex like building. 4 pillars are ACE inhibitor or ARNI, beta blocker, SGLT2 inhibitor and MRAs. In between comorbidities, iron deficiency, functional MR, mitraclip for mitral regurgitation, AF management, anticoagulation, diloxin for AF, LVBB, QRS more than 130, CRT, and if the heart rate is more than 70, ivabradine. In blacks population or CKD population or pregnant population where you cannot give ACE inhibitor and MRA, hydrogen isosorbate dinitrate, and variciguate for recurrent hospitalization, and for advanced LVSS devices and cardiac transplantation. I think this building approach you can go for, and if there is ejection fraction 35, then ICD is the treatment. So conclusion is, HFrEF management involves the 4 GDMT pillar. Rapid sequencing is the new mantra. When unable to up titrate, look for diuretic overuse or co-prescribed calcium channel blocker they don't have any survival benefit. Remove them and increase earning. Try to achieve maximum recommended dose as per guideline. Consider the role of iron, FCM, versigouate and ibabradine. And in a stable patient, escalate GDMT dose to maximum tolerated dose. Thank you all for patience hearing.
Very excellent and exclusive talk by Dr. Alok of the congestive heart failure. Any questions from the audience?
Do you prefer to initiate all the 4 drugs at once in a low doses, or you prefer that rapid sequencing, that is first combination of beta blocker SGLT2, then you will proceed? And what's your practical experience regarding using low dose, very low dose of ARNI, that is 25 mg BD, which is even not indicated in any literature, but we peoples are using it very frequently in a borderline systolic blood pressure situation like 90, or if patient is hemodynamically unstable, and we want to give them some benefit of ARNI, then we used to prescribe 25 mg BD.
Actually, there is no randomized data which have compared both strategies together. If you see historically, first ACE inhibitor came, then beta blocker over and above ACE inhibitor have been tested, then MRAs, then ARNI, and then SGLT2 inhibitor. But it have been seen, it was tested not because of any scientific basis. The way drug have been discovered, they have been tested. So it have been seen, if we can start all 4 as early as possible, then it will be the good. But in all heart failure patients which coming to our clinics or hospital, it is not possible to start all 4 in most of them because of the blood pressure issue, comorbidities issue. So it depends upon the several situation. In our situation, most of the patients, they don't have very good blood pressure. And if they are having good blood pressure, then we can start with all 4 drugs with the smaller doses. And what I do, what is my practice, I am telling, I always start with the plus combination, torsemide and spironolactone combination from day 1 full, and SGLT2 inhibitor full dose, and carvedilol if patient is not having COPD, then carvedilol with the low doses. Because carvedilol, apart from beta blocker, have a small vasodilating effect, and this vasodilating effects give symptomatic advantage. Because if you can remember, vasodilators once used in acute heart failure management. So, and after 2 weeks or after 1 week, if blood pressure is okay, then I go with the ARNI. If blood pressures are not good, then I up titrate the dose of beta blocker to the max. So from day 1, I am having the 2 drugs maximum dose and 3 drug dose. And if BP permits, and my personal opinion is that if instead of not starting a drug, better to start with the lower doses of ARNI. And if it's the same blood pressure patient is doing good, then it gives confidence to the increased doses of the ARNI. So I think, so I mostly start with 3 drugs. That is my strategy. And that works.
I think Dr. Avdesh's question is very valid. Low blood pressure is very common in heart failure patients in our country. But after the advent of verisuguate, I have changed my practice. If I am unable to move beyond a 25 milligram ARNI dose, I stop ARNI. I first start verisuguate, build it to the maximum dose, and I have seen in many times, not every case, but many times, ARNI can be restarted because verisuguate takes over the job. Right? This is one change which we have done.
Another thing is once there is a stage between acute decompensated and chronic heart failure patient. There are some patients which comes into the OPD, their heart rate is around 110, 108, but they are quite stable, they are fine crafts. In these subset of patients, if you use lenoxin, it gives very good result. It stabilizes your patients because digoxin is the only drug which increases the contractility, at the same time reduces the heart rate. All of the drug, if you will reduce the heart rate, contractility will become.
Sir, regarding Berisugat, I have some negative mindset regarding that. I am also using it, but because basically it's action based on vasodilatation, and any drug which causes sufficient or significant vasodilation will definitely cause hypotension. And though in the different trials, whether it is Victoria or whether it is Bacter, in none other trial they show significant hypotension. So I am still thinking that how it is not causing hypotension and causing so much vasodilatation that it is causing symptomatic improvement in heart failure.
I think
So
acute heart failure decision consensus pathway of American College of Cardiology 2024 have clearly shown SGLT2 inhibitor and MRA, because these two class of drugs, they have very little effect on the blood pressure. So start with them if there is no hyperkalemia, and if blood pressure permits, then go with the ERNI. If patient is fully compensated, then go with the smaller dose of beta blocker. That's what need to be done.
Alok,
Boss,
Alok,
can we
one
stop?
question. There is, though it doesn't come in the four pillars, but you said the beta blocker SGLT2 means you start in the beginning. If the patient is means blood pressure is not very good, it's about 90s or so. Heart rate is also around 90s. So, do you think you said that you do have liberty to add some other stuff as well? So, ivabradine, if you add, is it going to be of any benefit in that situation?
Ivabradine is need to be added in SIFT trial after maximum tolerated dose of beta blocker and still heart rate is more than 70. Then ivabradine have a role. And I have seen few of physicians add ivabradine at the upfront. Never add if any patient is having heart rate of 110 and having basal crepes. If you will add ivabradine, your patient will compensate, decompensate, because it is a tachycardia is a compensatory mechanism. Is that so? All benefit of beta blocker is not because of heart rate lowering. It is a neurohormonal modulator because of sympathetic inhibition is also there. So ivabradine is always secondary to the beta. It is a class 2A, 2B drug, and beta blocker is a class 1 drug. Yes, sir.
How to select a beta blocker in management of the CHF, either selective or non-selective?
Only 3 beta blockers need to be used. All beta blockers are not same.
Say,
All ACE inhibitors are same in heart failure.
yes,
Thick?
Yeah.
But all beta blockers are not same.
Not
ACE inhibitor is a class effect.
class.
Beta blocker is a not class effect. Carvedilol, bisoprolol, and metoprolol succinate.
Succinate, sir.
Beta lock is not approved in heart failure. Beta lock you can give in myocardial infarction or hypertension, but need not to be given in heart failure. So all beta blockers are not same.
Was one question.
Yeah.
Can we stop some medicines from GDMT group after LV function normalization?
You know, there is a TRED HF study which have looked into this question, whether we can stop drugs.
Any of them? Yes.
So it has been seen within a 6 months of stopping, in 50% of the patients, ejection fraction deteriorated. So except in peripartum cardiomyopathy and tachycardiomyopathy, these two conditions,
Myocarditis.
you have to continue the
Lifelong.
Life.
Yes.
That is the crux.
All the four drugs. Yes.
Momentum for the speaker. Momentum.
I invite Dr. Dharmendra Jain sir, the head of Department of Cardiology, Varanasi, for the next talk. I must congratulate Dr. Alok. He is having excellent talk, and I am very happy I am his batchmate.